Hello, everybody. My name's Professor Grant MacArthur, the Executive Director of the Victorian Comprehensive Cancer Centre Alliance. And on behalf of our partners, the Monash Partners Comprehensive Cancer Consortium, it's a real pleasure today to welcome you to this webinar, interactive webinar at a very critical time for our health system and a time when a lot of our minds are focused on the needs of our patients. Before we kick off, I would like to acknowledge the traditional owners across our wonderful nation, for everyone that are dialing in here to the webinar, acknowledge the traditional owners across the nation at all the sites that each of us are at, and pay my respects to elders past, present and emerging. So today we're going to tackle some difficult issues that we're all facing. The aim here is to connect the cancer community, to provide critical information that we've identified is in need urgently across the cancer sector to help us prepare and deliver optimal care for all cancer patients throughout Victoria and throughout Australia. And this will be interactive. We want to gather information from you about your needs, and then in Victoria we're putting together a task force with support from the Department of Health, the AMA, the Chief Medical Officer, to provide the information that's needed across the cancer sector so that we can optimise the way that we care for our patients across the whole cancer community. We've got almost 1,000 participants involved in this webinar today. It's interactive, so there's the ability through the Slido software to ask questions. Clearly, with such a large number of people, we're not going to be able to get to everyone's questions. However, we will undertake to analyse all questions, and that will factor into the Victorian Task Force and the information that each and every one of you requires to optimise that outcome across the cancer sector at this difficult time for everybody. Now, I'd now like to go on and introduce our panel, and I think we're able to put up a slide of our panel for you to see. If we could get that up, please. So on our panel today, we have Associate Professor Sue-Ann McLaughlin, who is the Medical Director, of Oncology and Cancer Services at St Vincent's Hospital in Melbourne. We have Dr. Andrew Hayden, who is the Joint Clinical Director of the Southern Melbourne Integrated Cancer Service and a medical oncologist at Alfred Health. We have Dr. Ziwan Wong from Peninsula Health. Z heads Cancer Services and Medical Oncology at Peninsula Health. And we also have Dr. David Speakman, who is a surgical oncologist and Chief Medical Officer at the Peter MacCallum Cancer Centre. I'm very happy to be joined by Professor Karen Thursky. Professor Thursky is an infectious diseases physician and at the Peter MacCallum Cancer Centre, and the leader of a national research program in implementation and health services research in cancer infections, and has expertise in particularly in support of patients with malignant hematological disorders. Real privilege to be joined by Professor Eva Sekulov, who is the Professor Director of Oncology at Monash University and Monash Health here in Melbourne. Two more to go in our introductions. Associate Professor Jerry Hanna, who is the Director of Radiation Oncology at the Peter MacCallum Cancer Centre. And finally, but certainly not least, Marion Lischke. Marion is the manager of the Parkville Cancer Clinical Trials Unit, a very large cancer clinical trials unit here in the Parkville precinct in Melbourne. So that's our panel, and without further ado, we're going to move to some questions from the audience, and thank you also to those that have sent some questions in. And there's a question for Karen Thursky about what are the risk factors for severe COVID-19 disease, and particularly patients with hematological malignancy that are immunosuppressed, are they at significant increased risk of coronavirus infection?
So, Grant, I think we can take that question in two ways. In terms of risk for severe COVID disease, we do have lots of data now that has come out from some of the big outbreaks such as China. And to reassure everyone that in the large majority of cases, this will be mild disease, and there'll be a small proportion, 15% or less, for that. For example, patients that have other comorbidities like high blood pressure and diabetes and airways disease. But we also know that in the cohort, the small amount of data that we had in the cancer population, we did see that in the Chinese experience that the lung cancer patients were overrepresented. We don't know all the information about the hematology patients, but we suspect that the risk for them having severe disease might be several times higher. We've estimated at least 3 times higher. We need more information about that. I guess we go back to basic principles with these patients because we know that they're already at risk for more severe disease with the other routine viruses that they get through the year, such as other coronaviruses, influenza. And so it comes back to really protecting our patients from getting viral infection.
Okay, thanks, Kaz. Can I just follow through with a question, please? It's just come through on Slido about recommendations regarding vaccination for seasonal influenza and Streptococcus pneumoniae.
That's a really, really good question, and absolutely one of the key strategies that we need to do is to make sure that our patients are prevented from getting infections that they are already at risk for. And we have already protocols well in place that are already currently being practiced by oncology and haematology services, which includes the influenza vaccine and other vaccines. Often they relate to timing after transplant, for example, but many units have these protocols well in place, and we should be focusing on making sure that we can get the compliance and vaccines to those patients as quickly as possible.
Okay, thanks very much, Kaz. We've got some questions coming through about clinical trials, and I might turn to Marion Lischke here. So thousands of patients are on clinical trials in Victoria at various stages of follow-up. How do we manage the priorities for those patients and manage our clinical trials during this pandemic?
So, Grant, I think the first priority is the safety of patients already on treatment, and where appropriate, the management of that treatment, the continuation of that treatment. Many people are concerned about the usual regulations and bureaucracy that trials bring with them, but we have found over the last week that communicating directly with sponsors and with the HREX, we have been able to get very good, broad, pragmatic approaches from both of those groups. For example, we've applied for blanket approvals for variations in our normal management, which both sponsors and HREX have approved. We are very concerned to make sure that we are not putting patients at risk by travel, and obviously many centres patients will travel a long way for their trial treatment. So we have already found that provision of telehealth and remote care can be organised quite quickly. Sponsors will have to accept that we can't always do everything that a trial would require, but keeping protocol deviation log for every patient will enable us to deal with this later on. Currently, our telehealth and remote care is for oral drugs. Intravenous drugs will be much harder to organise. Common drugs such as Pembro or Nivo or other immunotherapies may be able to be given at local chemotherapy centres close to people's homes, but we mustn't overwhelm those centres which also will be having staff and health issues of their own. This is something that we need to discuss very carefully with the doctors involved in the treatment and the patients themselves. There will be drugs that we cannot allocate to other centres to be given, and nor should we. We are responsible for the safety of our patients. And we need to look very carefully at whether the continuance of drugs that have a high incidence of acute side effects that might need inpatient or intensive care use, whether that should continue at this time. Most importantly, the clear communication between all staff, patients, HRECs and sponsors is what we really should be going for. And that's where we're at the moment. Okay.
Right, thanks very much, Marion. We've got a good question coming through from, I assume, a patient that I would like one of our medical oncologists to answer, please. So if a patient is in contact with a confirmed case of COVID-19 and needs to self-isolate, how will that be managed? Is there the ability to return to the hospital for the next treatment, or what would the advice be for patients that have to self-isolate? And I know it's a big, complicated question dependent on scenarios, but either Ziwan or Andrew, if you could address in principle how we're going to tackle that situation.
Hi, Grant. Andrew here. I might just say a few words and then Andrew can continue. I think it pretty much depends on what treatment the patient is on, and of course the actual patient condition as well, whether that's for curative intent or for palliative intent in someone with metastatic disease. So I think depending on the scenario, we will have to prioritize, and I believe that some of the centers are looking at setting up an isolation room to treat patients who may have contact or are waiting to be tested or who are being tested, who have no symptoms and who are otherwise well, who may be able to continue with some form of non-immunosuppressive treatment, for example. But I think if they are on, treatment which are associated with high risk, then I think the individual situation needs to be looked at on a case-by-case basis.
Okay, thanks very much. Thanks very much, Z. Questions come in about radiation oncology services, which I'll turn to Jerry Hanna to address. Jerry, there are concerns in health services about reductions in staffing. How do you think that will impact on the way that radiation oncology treatments are delivered in the setting of this viral situation?
Great question, and just to say, obviously, a bit like the rest of the health service, our demographic means that we will probably lose a number of our key staff as we go through this pandemic. With the with looking childcare, obviously staff themselves becoming ill and so on. What we want to do is, where best possible, we want to deliver the best radiotherapy service we can deliver to patients. And we want to prioritize those patients who will have the best chance of cure, and we're prioritizing those patients. We still, where possible, will try and undertake palliative treatments. Now, we will also ask some patients to defer their treatment by 3 months, where that deferral will not adversely affect the cancer control or their chances of a good outcome following that treatment. Where patients have started treatment, we will absolutely prioritize those patients completing their treatment. Now, how are we going to do this? One way we're doing this is to moving to shorter radiotherapy regimes known as hypofractionated radiotherapy. These regimes deliver bigger doses per fraction over a shorter period of time. That means less visits for the patients, less visits on the machines. That's a good thing in so many ways. That will allow us to cope with this rolling out pandemic. Why that's important is that we're changing those regimes now so that actually we're ready as staff numbers will drop as projected in 3 to 4 weeks' time. These regimes are as effective as current regimes, They're also comparably as safe in terms of toxicity. They just, in some instances, have less supporting evidence. There's less trial evidence, but we're not using anything that's unsafe or dangerous, or certainly less efficacious in terms of cancer control. I want to reassure everybody about that too as well. By doing this, this will allow us as best possible to cope and get through this COVID crisis.
Thanks very much, Jerry. Now we're going to lose Kaz Thursky relatively soon, so there's some questions coming through, I think, for you, Kaz, and others might want to back these couple up as well. So we'll just take them one at a time. The first one is, will we see and should we have temperature screening for visitors and staff entering hospitals during this COVID-19 management challenge?
Thanks, Grant. So I think people online need to be
I might get Kaz to...
Yep. Thanks, Grant. So I think the first thing to recognise is the current rate of positive tests at the moment. So this, Australia has one of the highest rates of testing in the world at the moment, and our current rate of positivity is still about 0.5 to 1%. And that means a vast majority of cases at the moment truly do have contacts of travellers, returned travellers. We are not at the point where we would be considering temperature checks coming into the hospital. And so I think we need to have a measured response as we go through the various phases, but at the moment we are not there yet.
And there's another question, Kaz, I might get you to take that's come through regarding medical and nursing staff and the use of masks. So should surgical or N95 masks be used routinely during close contact with patients on a ward, given that many cancer patients are immunocompromised?
I think we go back to the current standard of care that we normally provide. So if we are managing a patient who is admitted to hospital with an upper respiratory tract infection, the usual practice would be that those patients would be in respiratory isolation and the usual protective equipment is used. The use of N95 masks are being really reserved for those patients who are managing proven COVID patients or those staff that are performing very high-risk procedures. And that is pretty clear. We are obviously facing the risk of equipment shortages, and currently the information that we're providing our staff is that the routine use of masks in general patient care is not actually required at present.
So one interesting question has come up regarding whether clinical care teams should be divided into those that will care for patients with cancer and documented COVID-19 infection versus those that do not deal with COVID-19 infected patients. And perhaps, Kaz, what would your views be about that from an infectious disease point of view? And then I might get one of the oncology team to talk about the feasibility of that.
I can talk from the experience in the Parkville precinct with Royal Melbourne being across the road. So Peter Mac, for example, will be a clean hospital. We will not be holding proven infections in our hospital, and they'll be transferred to Royal Melbourne, where indeed they are actually splitting into COVID teams and non-COVID teams. Obviously, for other hospitals around Australia where there are not separate the hospitals, then it may very well be that you would be preferring that those staff looking after cancer patients would be part of a non-COVID team, and it would be a very reasonable approach.
Great. Now, and I think we now have David Speakman online. So, David, do you have views about recommendations about dividing teams between those that care for COVID positive patients and those that only treat COVID negative patients?
Sure. Thanks, Grant, and thanks everyone for joining in. I think it's a very valuable webinar. So I think absolutely, looking after your staff is a key thing that we've been trying to deal with, because international experience would suggest that anywhere up to 40 to 50% of your staff you might lose, and therefore what sort of service can you deliver in those circumstances? I think there's different strokes for different folks. We've got some very highly specialised areas where there's only one or two oncologists. In those areas, we've tried to take the designated survivor approach and keep them apart, not having their day-to-day contact that they might normally have. And in other areas, we've absolutely tried to cohort into teams, so that one particularly with the junior staff, I think it's most important, who are usually together all the time, that we're trying to break them into separate teams as much as possible, so that if one team does get a positive result or falls over, then we've got another team that's able to continue. But I think everyone will have to do that, depend on what their particular circumstance is. But I can't emphasise enough that looking after your staff in terms of the messages about hand hygiene, keeping clean, social distancing, I think, to echo what Kaz has probably said already, these are the key messages we're trying to get to everyone right at the moment, because they are the most effective strategies to stop the spread of it within the staff, but was also within the patient group.
And Grant, can I just finish on from that? Where it's possible, we are actually keeping staff at home, working from home remotely. Yeah, and so just so where we can do remote working, such as our radiotherapy planning at home, we're actually keeping staff at home to do that too as well.
I think, Grant, the other thing to mention, sorry, just to jump in about all this is, which I'm sorry if anyone's mentioned this already, I think in our clinics already in the last week, there's nothing like something like this to cause a bit of disruption in the health service. We have seen the majority of our patients in the clinic now by telehealth or by phone. Not possible for everyone, but the more you can do that, the safer it is for your staff and the safer it is for your patients. So I think actually there's great assistance to be had from your IT department and everyone else to get this sort of stuff up and running in a hurry, because lots of patients can be seen in this way.
Okay, thanks very much, David, and good message about protecting the staff. Look, I might share that I received, what to me was a real message of hope from Northern Italy overnight, where, one hospital in Northern Italy that one of my colleagues works at have treated 600 inpatients with COVID. I think we all know about the very challenging situations in Northern Italy, but despite that, only 10% of medical staff in that hospital in Northern Italy became positive for the virus. So, that is lower than I might have expected. So, I think there is reason for hope there. Okay, so next question, I might turn to Andrew Hayden, if I may, has come through. And this is a question about patients with solid tumours that many are older and have comorbidities. Andrew, what do you think the issues are for those particular patients? Not getting a response from Andrew, so I might actually see if either would you like to try that question? So older patients with comorbidities, with solid tumours, what are the issues?
Thanks, Grant. I think maybe is Andrew muted perhaps? Maybe. I might just take the question first. I think the older patients, some of them have a lot of comorbidities and maybe more frail than what they appear to be coming through the clinic. And I'm just referring to, some of us who looked after some of these older patients believe that, and that's backed by good evidence, that they should be assessed appropriately with a geriatric assessment, if not a screening at the first instance. And some of these patients may or may not be suitable to have high-risk treatment at the first instance. And I guess the other issues with their multiple comorbidities, they are at higher risk of side effects from treatment, and their ability to actually go back to their baseline functional status may be reduced if they are more frail. So I think those are the important considerations for us. And I think in certain parts of Victoria, certainly in the southern part where I am in the peninsula, we do have a large a large number of patients who are much older, above age 65 to 70, and I think that's always something to bear in mind when we're seeing them. And in the situation with COVID-19, I think they are also the group who are at the highest risk of complications related to the viral infection and mortality risk as well.
Okay, thanks very much, Z. So certainly solid tumour patients that are elderly are a vulnerable group. There is, of course, other patients that are vulnerable, often those that are more geographically isolated. And I know Eva Sekulov has particular interest in vulnerable groups in the cancer community. Eva, maybe first, and then David Speakman might make comment about, patients in more remote areas, recognising that we do have on the line a number of colleagues from around the country. Eva, what do you think can be done to support those patients, particularly getting access to tertiary centres at a time when people cannot travel? All right, apologies everyone, as it's obvious that we're having technical problems here trying to do absolute social distancing of our panel, and getting everyone linked in together is not easy. So thank you for your understanding there. David, would you like to take this question about you work at a tertiary centre. There are a lot of patients that are remote from the Peter Mac where you work. What do you think can be the recommendations for regional and remote patients linking into tertiary centres around the country?
So I think very important question, Grant. I think we have to be able to be thinking about telehealth. I think we're very lucky that a guy like Sabe Sebison had got teletrials and that type of thing rolling already. And so a lot of links have been created around the country already, some established, but some not. And I think we have to use telehealth to its maximal advantage in this scenario, to both for a place like Peter Mac to reassure patients that they are getting the best possible care locally, and that if they need care that they can't receive locally, then finding novel ways with country centres or regional centres about how places like the Peter Mac can help them, whether that's us sending the resource to the country or determining if it is actually in the patient's best interest to move from a regional centre to town. Because I think we have to remember in all this that your family are around you, and how we can look after the whole person, not just the cancer. We're very wary of transplanting patients and their families out of their hometown at the minute, particularly coming to a centre where COVID might be more, to major centres where COVID might be more of an issue. So I think the stronger the relations between various clinicians around the country, and that you can always put your hand up and ask for help, and to do telehealth consults, I think that's the particular advantage we've got in that area.
Thanks very much, David. Coming through with your questions, there's a lot of enthusiasm to get the home chemotherapy question addressed after our technical problems. And so I might get Z to make a comment about home chemotherapy, and is this something that is an important part of the response for the care of patients in this situation?
Thanks, Brian. This is an absolutely important area to address. At Peninsula, at the moment, we have not embarked on home-based chemotherapy. We were just starting to look at how to implement and have done some preparatory work, but I do believe that there are other centres in Melbourne which have already rolled this out for a while now, but I do not know the exact percentage of patients who are being treated at the home compared to the general total number of patients treated at the centre. Absolutely important area to look into, I think, in terms of how we can minimise patients visiting to the health service. But I think we also need to bear in mind the resources that we require at the health service itself, trying to implement home-based treatment, and what sort of service model we're going to utilise. Do we use, staff from the chemotherapy day unit? Do we have a centralized, group of staff who will go out to all the patients in a certain geographical area? Or do we use, a combination of chemotherapy staff and hospital in the home within the health service? So I'm aware there are various models that are being used across the state and elsewhere. So I think it's important, at this time, resources permitting, of course, to see how many of these patients can actually be treated at home. And I think that this perhaps, if we're able to actually explore this option concurrently with what we're doing at the moment, that will be great. But I think each individual health service probably have our own, situation and circumstances which are unique. And I think we just have to work around this, but certainly an important area to explore at this very important time. Thanks, Grant.
Thanks very much for that, Z. High internet traffic at the moment, but technically we're having problems, so please bear with us. I know there's still a lot of people listening to the webinar, and I want to ensure you that we will be editing this down so you can re-watch, plus also generating the questions to present online through our websites. But whilst I want to stick to this neoadjuvant question, if I could, and Andrew, do we have you now? If not, maybe David Speakman. I know David is a surgical oncologist with an experience with neoadjuvant therapy, both in the setting of breast cancer and also in melanoma. David, would you like to make a comment about neoadjuvant therapy, more or less?
Thanks, Grant. I think the challenge with more is the capacity of the staff to deliver it. And I think it will actually it will be tumour dependent. I think it's pretty clear, for example, in breast, that a HER2 positive tumour or a triple negative tumour might be better treated with upfront chemo, although you could debate that all day. I think that plays into the other question about your resources. So if I did take breast cancer for a minute, I think that in Victoria, the state government...
Thanks, Andrew. Yeah, we've got a bad line with you, unfortunately. So, so I think we've had a response there from David. Thank you very much.
Great.
So a question, maybe I'll get David Speakman to address as well. And I might make comment myself after David, and that is about the private and public sector cancer units working together during this pandemic. David, what are your thoughts?
I think Grant, thank you. We have to utilise all the resources that a state has or to continue to deliver the best possible cancer care to patients. That's what I was going to say. I think that it will be a bit tumour strain dependent, that cases, for example, there are a lot of breast cases that could be done easily and perhaps safer for a patient in a low-level private hospital environment than necessarily in a place like the Peter Mac. And we're actively exploring how that type of thing might work, where clearly there are other cases that, because of the nursing and allied health and intensive care type support or high-level support that's needed, your only option is to do them in a larger tertiary hospital. And indeed, so as I'm sure is happening elsewhere across the nation, the Royal Melbourne and the Peter Mac are constantly talking at the moment about how we might help the cancer load in the Royal Melbourne by doing various types of surgery at Peter Mac that will clear their beds for COVID patients. I'm sure that's happening to an extent everywhere. And I think Jerry will comment about the same type of thing in radiotherapy. But I think all these options have to be explored, provided they can be done by giving safe care to the patients.
And just Grant, to follow up on the radiotherapy angle, we really have had a lot of liaison across Australia, not just in Victoria, amongst the directors of both public and private hospitals to say, how do we respond to this unprecedented situation? We've drafted up a fractionation list. We are very happy to share that our plan for that with anybody who wants to do it. The college has given some very general level detail. We've put a lot more flesh on those bones, so to speak, and that's certainly available to anybody who wants, if they want to contact me directly, Peter Mack.
Thank you very much, Jerry. Look, I think that that's a great message, and you know, as I mentioned at the outset, for anyone that joined late, that we are setting up a Victorian task force. One of the key aims of that will be garnering what information you require across the cancer community and providing some guidance documents for you to interpret and into your local treatment setting in your institution. So Jerry's example there of sharing the radiation oncology documents is very worthwhile. May I also just follow on from David's comments about and Jerry's comments about private and public sectors, to say that the Victorian government are indeed actively working on, you know, potential plans where the capacity in the health system with a reduction in elective surgery can be maintained for more pressing clinical care, such as cancer, across both sectors. So that's being actively looked at. Okay, so could I now turn? There's quite a few questions coming in about the various treatment options, and this will be something that's key for the task force to provide people with some guidance on. You know, are there preferred treatment options in this scenario? But I might turn to Sue-Ann McLaughlin, from Director of Cancer Services at St Vincent's Hospital, about how the pandemic is potentially influencing the treatment options that we can provide for our patients.
Thanks, Grant. I think just going back to some of the things said by the people, particularly about sharing resources, I think there's a strong spirit of sharing, particularly in Victoria, and I'm sure this is going along in Australia as well, but we're all grappling with how to, you know, write documents, write protocols in this regard. And there's a few already circulating in regards to treatment practices and clinical care, written by prominent Australian oncologists and a couple, or at least one coming out from the US. And I think these documents are going to be incredibly important so that we don't all have to reinvent the wheel. It'll be important to modify the documents according to your own context, but it will save a lot of time for all of us to have these documents available so that we can use them to think about treatment that is appropriate in this situation. So the documents that have already been written are there's a lot of commonality across them in terms of how we should approach things. They seem to be very sensible in their recommendations about mitigating risk. So I think it's important that we all have access to these documents. And I think the underlying principle is about limiting the amount of time patients spend at the hospital and mitigating risk associated with their treatment. So the sorts of things that are coming through in the documents are preferring oral agents, perhaps the use of GCSF to mitigate myelosuppression, shorter treatment courses where possible, putting supportive care treatment that doesn't impact survival off for a time, limiting steroid use where we can, careful use of antibiotics to preserve resources. These are the sorts of things that are coming through in the document. The other thing about these documents, I think that is really reassuring for us, is that the decisions we're making will be, if we share these resources, similar across our institutions, so that patients will have equity of care as much as is possible. We don't know how this is going to evolve and how individual centres' resources will be impacted. But I think what's really important, if we can, is to maintain equity, be doing the same sorts of things across the board. It won't be perfect, but I think that's what we should be trying to aim for.
Great, thanks very much, Sue-Ann. Now, what I will do now is I'm going to go one by one and ask the panel members the same question and get their response. And I will begin with Sue-Ann, who we've just had speaking. And then I'll do a sum up about next steps for everyone. Again, sincere apologies about the technology, but we will have other ways of communicating with all of you at this difficult time for everybody. Now, the question I want to ask the whole panel, we'll go one by one, is that in this time of uncertainty, what gives you hope? And I'll start with Sue-Ann, if I may.
I think what gives me hope is the strong sense of sharing that is already apparent amongst the cancer community. I think that's not surprising. I think we are a close-knit community in Australia, and gives me a lot of hope that people have been very willing to share resources and to support each other through this very difficult time.
So I'll now turn to Marion Lischke. Same question. Marion, at this time of uncertainty in the clinical trials area in particular, what does give you hope?
I think very much echoing Sue-Ann and many of the things that have been said at this webinar is the willingness of people to work together and to look for novel and new ways to achieve what we've previously achieved. In particular, the use of telehealth, distance and remote care, and the willingness of regulators to accept that what we always did in the past may not necessarily be correct today, and that we look for new ways to achieve what we've previously achieved without putting anyone at risk.
Thanks very much, Marion. And I note that in Queensland, also Monash Partners Comprehensive Cancer Consortium and the Victorian Comprehensive Cancer Centre Alliance have all been actively working on teletrials. And Marion, I would predict that that is going to be given a major boost forward, those programs, as a result of the learnings coming out of the situation we're in at the moment. So thanks very much.
Absolutely. I think we're doing them by default.
Yeah. Now I'd like to turn to Eva Sekulov. Eva's been working night and day on the issues and challenges facing the oncology and cancer community at the moment with the COVID-19 situation. Eva, what gives you hope? Yeah, I think Eva's connection may be not so high quality. I might turn to Z1. Z, outer metropolitan care, regional care. In this situation, there are challenges for you and for those in the regions. But what does give you hope?
Thanks, Grant. I think regardless of where we are, I think what really gives me hope is the unity and the solidarity of the entire community coming together, regardless of whether it's medical staff, nursing, allied health, or research staff, or administrative. We're all trying to do what we can, and we're trying to be flexible, in what we're doing every day to see, can we perhaps, think of a way to try and tackle this together as a community. So I think that spirit has been just amazing. Just this morning I was talking to my research staff, and we're looking at how we can perhaps deploy the research staff with nursing background to do some nursing work while we are trying to scale back on the clinical trial sort of work in the next few weeks. So that's just amazing. And also communicating with my colleagues from overseas and, sharing what they're doing over there, what's worked to contain the virus over there and what did not seem to work so well, and taking that experience on board. I think that's been just amazing to see how we all stand together against this invisible enemy.
Thanks very much, Z. So I'll last go to David Speakman, followed by Jerry Hanna, to please give us what brings you hope. at this time of uncertainty?
I think without doubt, Grant, the resilience and determination of the staff who work not just in cancer centres but across the health system in Victoria and Australia. Every time I've ever asked what's the best asset we have, that's the answer. And I've no doubt they'll rise to this challenge. And I think the other thing that gives all of us hope is the resilience and strength of the patients that we're looking after.
And Grant, fully echo that. How could I say any better? Thank you.
Thanks very much, Jerry. So I'll get the team now to put up our final slide about staying connected, because this is very important. And, you know, there still is almost 650 people online dialing into the webinar. I, you know, really appreciate you sticking with us with all the technical challenges, but staying connected is vital. There is the Victorian Task Force being put together, and the VCCC Alliance and MPCCC will generate a network hub that you can get access to information. And one excellent question came through after Sue-Ann talked about the documents, where can they be accessed? So as a priority, and this week, we will get those to you as an absolute priority. You will receive an email, old-fashioned technology, I know, but as you've seen, new technology at times of difficult internet capacity is a challenge. So you'll receive an email that will link you into that clinical network hub. There will be social media through Twitter, LinkedIn, Facebook. And very, very important here is support for patients and carers. In Victoria, you can see on the slide the cancer support line. There are support lines provided throughout the nation. At the moment, our cancer support line services are coping well with the demand from patients. So I encourage patients and carers to use these support lines. Of course, stay in contact with your clinical teams that you're involved with the care, and we will be providing information. Our task force does include consumer representatives and also the director of the cancer support line in Victoria is on our task force. So we will, part of our work is to ensure across our whole sector that patients and their families and their carers stay well connected. So it just leaves me now to finish up and to just really thank all of you, all of our colleagues across the cancer community, the Monash Partners Comprehensive Cancer Consortium team, the VCCC team. And I think as our panel have summed up really well with what gives you hope, we're all in this together, we're supporting each other. And personally, you know, I have great confidence that we'll get through this together in Victoria at least as well, if not better, than anywhere else in the world. And I think that is echoed across our great nation. So thank you very much for your attendance and your patience with the technology. Thank you.